Greetings to everybody. I'm Professor Yasser El-Hawary, and in the coming 15 minutes I will try to solve the dilemma of low back pain. First of all, when you say this patient has got low back pain, this is not a diagnosis. This is a patient complaint. So please stop saying low back pain as a diagnosis. The incidence is very high. Nearly 100% of the population will get back pain anytime in their lifetime. In US alone, there is 27% of the population has low back pain, and there's an addition of 7% every year. So it's a big problem. The causes is a large spectrum. It ranges from mild things like lumbago and muscle strain, or a fatal thing like a ruptured aortic aneurysm or metastasis. So please don't mix up the red with the blue. The cause of the pain is can be anything, starting from the skin to the bone. So the facets can be a cause, osteoarthritis, the outer annulus in disc degeneration. The muscles could be injured, ligaments. So it's a wide range of pain generators. So you can either start and excluding or do a differential diagnosis by excluding every disease by its own, but this will take a lot of time and will be not cost effective. So it will be much easier if you try to categorize the pain into syndromes. For example, you can diagnose a patient with entrapment syndrome, claudication syndrome, instability syndrome, osteoarthritis syndrome, spondylitis or spine infection syndrome, pathological fracture syndrome, anxiety syndrome, spinal arthropathy, and if it doesn't fit in the last 8, then you put it under miscellaneous. So in the entrapment syndrome, which is the most common presentation, patient presents with leg pain, usually across a known route. If the pain goes to the big toe, it's L5. Numbness to the little toe, it's S1. And numbness is a pathognomonic of a nerve. No other structure in the leg can cause numbness. And the pain crosses the knee, and there is rest pain. So the patient can get pain even at rest. An example is a prolapsed disc, and once the conservative treatment fails and you go and remove the prolapsed disc, the patient gets better. In the claudication syndrome, it is characterized by leg pain while walking, and the patient, if sits or bends forward, the pain goes, and there is no rest pain. There are minimum signs, and if you want to elicit a positive sign like a weakness, like for example lost ankle reflex, knee reflex, you have to do provocative test. Ask the patient to go up down the stairs several times and come back and re-examine, or put the patient on an exercise bike for 5 minutes and re-examine, and then you can elicit more signs. This is an MRI of a multiple level stenosis, and you would expect in a patient like this you get much signs, but not. And you would expect in the patient like this, the patient will present with weakness, but usually this is not the case. In the instability syndrome, it's like instability of the knee. Once you use the back or use the knee, then you get the symptoms, and usually it's back pain. There's occasional leg pain. It's increased by activity. There is no rest pain, and if you use a brace, the patient gets better. An example is spondylolysis or spondylolisthesis, and remember that plain X-ray tells you a lot, and it's important in case in the instability syndrome. And ask for a dynamic X-rays, flexion and extension, and this will elicit the instability or the spondylolysis, and also the oblique X-rays for spondylolysis. In the osteoarthritis syndrome, it's similar to the osteoarthritis of the knee. You get morning stiffness. It's better till the afternoon. There is rest pain. It's mainly back pain. It's worse if you wear a brace. And X-rays can tell you there is osteoarthritis of the facet. There is osteophytes, and CT also is beneficial in case of spondylosis. In the spondylitis syndrome, it's the infection of the spine, either the disc or the body, or combined. Patient presents with severe back pain. There is night pain. The pain is unrest or activity, and there are general symptoms of infection, and it's mainly back pain. And if there is destruction of the bodies, you can get a deformity. The infection could be specific, like TB, brucella, or non-specific, like postoperative discitis or postoperative infection. Usually the patient with infection is a sick patient, and there's increased inflammatory markers, C-reactive protein, ESR, and usually CT will show you any destruction of the bone, and the MRI will show you early destruction or affection of the disc. And if you use the PET-CT, it's very effective in diagnosing infection. In the pathological fracture syndrome, there is usually a history of fracture, maybe a minor fracture like cuffing or bending. The pain is at rest. There's a kyphosis due to the fractured vertebrae and the osteoporosis. It's progressive. There's usually no leg pain, and usually it's in females above the age of. Please don't forget that if a patient has got a long bone fracture, like this lady who had a fracture of the neck of the humerus, and she had previous fracture. You can see the previous fracture is doesn't show a signal in the T2, but a recent fracture does. And the MRI can differentiate between recent and old. In the anxiety syndrome, usually it's a female or a worker which is seeking compensation. The pain doesn't go with the anatomy. The patient is reactive to examination, and examples are fibromyalgia, chronic fatigue syndrome. In spinal arthropathies, we no longer say ankylosing spondylitis. We say this group of conditions called spinal arthropathies. Patient can present with axial or peripheral pain. Radiology could be positive or negative, and examples are ankylosing spondylitis, inflammatory bowel syndrome, psoriatic, ulcerative colitis, Crohn's disease, and arthritis. Early diagnosis can prevent ankylosis in SPA cases. So look for the first sign in the pelvis, which is sacroiliitis. First sign in the spine is squaring of L4. Don't wait for the bamboo spine, because that will be too late. And if you want to really diagnose ankylosing early, do an MRI of the sacroiliac, and then you will find that there is edema of the sacroiliac joint. Labs like ESR, C-reactive protein, maybe they are not specific, but they can tell there is inflammation. HLA B27 is a strong positive, but even if it's negative, it does not exclude SPA. Miscellaneous syndromes, these are pain which is not related to upper syndromes. It could be gynecological conditions, but usually this is sacral pain. It could be renal, usually it's one side, and it's loin pains in the form of colics. Muscular is widespread, and it can take the shape of the muscle. So there are important questions you have to ask the patient. Is it back pain, leg pain, combined? Because each side can lead you to one of the syndromes. And if the pain is below the belt or above the belt, because below the belt usually it's L4 and L5, and these are the most common affected vertebrae. So in reaching a diagnosis using these syndromes, there is no overlap between the syndromes. And even if the patient is having two conditions like osteoarthritis and then canal stenosis, go with which is the main symptoms. If it's claudication, then put the patient in the claudication syndrome. If it's osteoarthritis and pain and morning stiffness, then you put the patient in the osteoarthritis syndrome. A plain X-ray is beneficial, don't drop it, and functional X-ray in cases of instability or low back pain is beneficial. EMG in case of radicular pain or muscle wasting. CT scan if you want to see the bone, but ask for a thin slice CT and the bone window. If you want to see the soft tissue, the neural tissue, you go for the MRI. So in diagnosis, it should be time efficient, it should be cost efficient. There is nothing called all for all. Don't do all investigations for all patients, and avoid a patient going from acute low back pain to chronic low back pain, because once it's a chronic pain, that's difficult to treat and needs different drug therapy and other therapies. In pain management, we use mainly the non-steroidal. Usually it's number one. We should use a safe, efficient, maybe selective COX-2 inhibitors. Paracetamol can be used. It doesn't have GIT symptoms like the non-steroidal. Muscle relaxant, use it if there is muscle spasm. If not, it will not work. If the patient has got leg pain, then ACTH will work, and anti-neuritis agents will work like pregabalins, gabapentins, duloxetine, venlafaxine, and you should of course treat the cause. This is a NASS study on the guidelines of treating low back pain, and it was published 2020, and it graded the recommendations to 4 grades. Grade A, there is a good evidence. Grade B is a fair evidence. Grade C, poor evidence, and grade I is insufficient evidence. So, with physical therapy and psychotherapy guidelines, cognitive behavior therapy (CBT), which was introduced in 1960, had strong evidence. Fear avoidance behavior (FA), introduced 2016, got grade A. Kinesiophobia treatment, introduced 2013, got grade B. Back school and handouts given to the patient, which was introduced in 1980, got grade A. McKenzie exercises has insufficient evidence. Spinal manipulative therapy, SMT, got C. And short periods of bed rest, 3 to 7 days, got B. So there is no strong evidence of putting the patient to rest. In physiotherapy, local heat or cold got grade B. TENS, transcutaneous nerve stimulation, there's insufficient evidence. There's no strong evidence for traction. Acupuncture, again, had insufficient. Brace massage, insufficient. Yoga had B. And aerobic exercises got A. In pharmacological treatment, steroids had B evidence, opioids B evidence, topical treatment had insufficient evidence, capsicum had strong evidence that it works, non-steroidal had B evidence, and selective versus non-selective has got insufficient evidence. So in conclusion, it's no longer a dilemma. You should categorize the patient complaints and signs and syndromes. This is cost effective. Psychotherapy, physiotherapy, back school has got strong evidence. There is no bed rest, and you should eliminate the cause and start with pain relief. Thank you, everybody.